Hi, this is Mrs. Hauk continuing with the second PowerPoint for dysrhythmias. I left off with SVT, that's where we'll pick up. Supraventricular tachycardia is caused by an irritable atrial focus. There is a rapid stimulation of 150 to 300 beats per minute. And the reason it's able to do that is it finds a pathway that it can just use again and again and again. And that's called a re-entry mechanism. So that allows it to be rapid. You cannot usually see the P waves. You're usually hidden in the previous T wave because it's so fast. The rhythm is regular and the QRS interval is normal. So those are some signs to look for an SVT. You can see here in this picture, there's an irritable focus that fires to the AV node, and it finds that same pathway again and again, and it just keeps coming back around to fire, and it will send the patient into a rapid rhythm. That's what it would look like on a strip. You can count and see if you can get an accurate count of a heart rate there, but you can see it's hard to tell where the P wave actually begins, the T wave ends. It's kind of pushed together. What are some causes? It's found to be common actually in children and young women for no identifiable cause. But anything that would stimulate the heart, like the three coping mechanisms of caffeine, nicotine, and alcohol, and stress, and of course sympathomimetic drugs. And what do I mean by sympathomimetic? We'll talk about that in class. So anything that's going to stimulate the heart, irritate the heart, is going to cause SVT. So how do we treat it? Well, we start with the less invasive first. Now, if your patient is unstable, meaning they have a decreased level of consciousness, they're severely hypotensive, we're going to do an electrical cardioversion. Or if at some point while trying to treat the patient medically, they become unstable, then we have to do electrical cardioversion. And we'll talk about cardioversion versus defibrillation when we talk about ventricular dysrhythmias. So, like I said, the least invasive first. So vagal maneuvers, coughing, holding your breath and bearing down. Of course, don't let them do it long enough to pass out. Anything that's going to cause the Valsalva maneuver. So if the patient is on a ventilator and intubated, you can suction them and make them cough. You can suction the back of their throat with a Yankow or make them gag. I've only seen the cold water used once, but if you've ever taken a dive into a very cold body of water and the shock that your body faces, that in itself could do it. So, but this is a little cool to somebody who's very awake and alert. What kind of medications do we use? Well, since they're in a fast rhythm and they have the potential to lose the ability to perfuse very well, we stick them on oxygen. And diltiazem and adenosine are used also. Diltiazem will help slow the conduction at the AV node, and adenosine, which we're going to talk about on the next slide, actually tries to help convert the rhythm. Now, if this is a problem that occurs over and over again and cannot be controlled by medications, then the next treatment would be an ablation, where they would stick a catheter in your groin and go up to the irritable cell and either cold ablate it or heat ablate it. So adenosine, drug used to convert SVT to normal sinus rhythm. Adenosine is not really used for anything else but SVT. Now, if the rhythm is, they're unable to tell if it's SVT versus AFib, they might try it just to try to differentiate what rhythm it is. But this is the only rhythm that adenosine is going to convert. We call it a chemical cardioversion. What it does is it interrupts the impulses of the SVT that's causing the SVT and allows the SA node to take over and fire again. It's only active in your bloodstream for 1 to 2 minutes, so you must inject it as close as possible to central circulation. So you're not going to inject it into a hand IV unless you have nothing else available. You want to do a central line or an Anacube IV, and it has to be followed by a rapid bolus of 20 mLs of saline. So we get it into that circulation and it can get to the heart before the effects of it wear off. It can result in a 20 to 30 second period of profound bradycardia or asystole. And so before administering this drug, you need to tell your patient you're going to get a warm, flushed feeling. You may even feel like you're going to pass out. So that's SVT. In class, I will show you a YouTube video of someone in SVT receiving adenosine. So you get an idea of how that works. Then on to AFib, our most common dysrhythmia. This number is probably a little low, 5 million Americans. It's probably gone a little higher, even though I did update this, I want to say 2019. Greater than 80% of AFib patients are over 65, and the prevalence of AFib is supposed to double over the next 50 years. And if you think about it, you've probably seen tons of commercials for people, different types of blood thinners for people with AFib. And the research and the innovation for treating AFib is going to continue just because it's going to be such a huge issue for people in the future. It accounts for about 1/3 of hospital admissions that people are admitted for dysrhythmias. What happens in AFib is that there's not just one cell firing in the atria, there's multiple cells firing in the atria. Very chaotic and very rapid, greater than 350 beats per minute. Basically, the atrium is left to quiver. So since the emission of the impulses is chaotic and so rapid, the AV node tries to control transmission to the ventricles. So it's chaotic, so that the impulses getting through the AV node are going to be very irregular, therefore creating a very irregular rhythm. I just said they just quiver. The problem with quivering is that blood pools in the atrium and can lead to clot formation. And this increases your risk of stroke greatly. There is a little outpouching of your left atrium called the left atrial appendage. And if we were in class, I would draw you a rough picture of what this looks like. And that's where a lot of the blood pools and clots. The other problem with AFib is rapid and irregular ventricular rate decreases ventricular filling time and reduces cardiac output. The ventricles don't have a lot of time to fill, and therefore they're not putting out a good output. AFib can be intermittent, which is paroxysmal, or chronic. And those who have chronic AFib, their body has adjusted to this chronic irregularity, and they will have a normal heart rate, a normal blood pressure with this chronic condition. We call it controlled or uncontrolled based on the ventricular rate. If the ventricular rate is less than 100, it's a controlled AFib. If it's uncontrolled, then it's going to be greater than 100. And actually, we will call a rapid AFib AFib with rapid ventricular response, or you may see it abbreviated AFib with RVR. So our rate, atrial rate, is too fast to count. Our ventricular rate will vary. Our rhythm is irregular. You will not be able to see P waves, and therefore there will be no measurable PR. This is a great strip of AFib here. You can see there's no visible P waves. You might say, oh, well, what's that? It could be, but do you see anything that's consistent? Not till way out here. It's just a wavy line, and it's irregular. No P waves, irregular, think immediately AFib. This picture just depicts that there's many cells firing and getting to the AV node. So how do we treat AFib? Well, we come back to that metoprolol tartrate. We're going to treat it with either metoprolol or diltiazem, amiodarone, digoxin if the patient's in heart failure, or any combination of those. So you need something to control the rate, and then you need something for anticoagulation. It used to be everybody got put on Coumadin, but now there are so many more different drugs available. As long as the patient doesn't have any problems with their heart valves, they can take Eliquis, they can take Xarelto, and then they don't have to have their blood work checked for levels. The downside to that is Coumadin is easily reversible. Do you remember what the reversal agent is for Coumadin? Whereas drugs like Eliquis and Xarelto don't have a reversal agent. Treatment, some patients will get a cardioversion. However, they have to have a TEE first before they can be cardioverted. Do you know what a TEE stands for? If not, we'll talk about it in class. They're looking for a clot sitting in the atrium, especially in that left atrial appendage. They see a clot, they are not going to cardiovert because they don't want to take any chances of knocking that clot out with a shock and sending it to the brain and causing a stroke. And that's why the patient needs to be anticoagulated first. So no clots can form while they're waiting. But however, the anticoagulation won't break up existing clots. So radiofrequency catheter ablation is also used for AFib, and cardioversion usually doesn't last. It may convert the patient to sinus rhythm. They may last a minute, they may last a week, they may last a month, they may last a year, but it usually comes back. Somebody who hasn't had any success with any of these treatments would qualify for the ablation. Basically, they make scar tissue by burning that will disconnect that pathway that's causing the AFib. I don't know that they do AV node ablations so much anymore, because if you do an AV node ablation, then you need to have a permanent pacemaker because they don't totally disconnect the ability to conduct from the atria to the ventricles with AV node ablation. That's just a picture of what the radiofrequency ablation would look like. The catheter through the groin, up through the artery or the vein into the heart. Some other treatments here, I have the Maze procedure. This is not, you don't have your chest cut open just to have this done. This is part of an open heart procedure. If you have a history of AFib, they might make a maze of sutures to try to interrupt that electrical pathway. Something else that they'll do during open heart surgery is a left atrial appendage ligation. They tie off that left atrial appendage so that blood will no longer collect out there and clot. And anything that's in that outpouching, if there is clotting, will not be able to be expelled out of it. There's also other treatments that are being used. If you've ever heard of the Watchman procedure, where they go through a catheter in your groin and they place like a coil in that left atrial appendage so that no clots can form there. So there's many different treatments that are coming about to help with not really the control of AFib, but to decrease the risk of strokes from blood clotting. And then there's atrial flutter. I'm running out of time on this podcast, so I will start the next one with atrial flutter.